Okay, so this is the part of the Wigan Primary Care webinar series. I'm going to hand over to Matt and Catherine, who's going to give us an introduction on how personalised care in secondary primary care for cancer is part of the long-term cancer plan. Over to you, Matt.
Thanks, Rob. Good afternoon, everyone. So I'm Matt Irving, a practice educator for Wigan Trust, and we've also got Catherine Place on the call as well. She's a transformation manager at Wigan. So we're looking today at sort of cancer as a personalised care intervention now. Some parts that make up that. So we're transforming the way that cancer follow-ups are done, and we're looking at how this is managed through different levels of patient stratified follow-up. So defining those and looking at who is eligible for which pathway, how it's supported for it, and how we can sort of work together with primary care and the trust to help implement this and support patients. So to give us a little bit of an overview, the total prevalence of cancer in Wigan numbers are here. So between January the 1st and December the 31st last year, we had 2,341 diagnosed cancers in the borough. We're running those same numbers again. We're looking now from January the 1st this year to the current day, the number stands at around 1,609. So that's up until sort of the mid-November. And this represents a reduction of about 25% year on year. But obviously we would normally expect this number to increase as well as patients are living longer with cancer. But obviously mitigating factors that we all know are currently affecting us have reduced this number. But we're still looking around about 1,800 or so patients by the end of the year who've had cancer, and a large number of those moving on to living with and beyond disease. So the number of people nationally is going to rise from around about 2.3 million in 2018 to about 2.8 million in 2023. Now, this number is the number of people who are living with and beyond cancer, not just diagnosis, and this is representing about an 18% increase in numbers. So by 2028, the trajectory on that will take us to around about 3.3 million people nationally, again representing about a 40% increase compared to 2018. So we know that a lot of people are living longer with cancer now, and obviously the support services that facilitate this will be stretched. So we're looking at ways that we can manage our patients to support them and help them living with and beyond cancer. And the National Cancer Survivorship Initiative has looked at the current models that support people and decided that these are inadequate now. The number of people who are coming up with unmet physical needs, whether it be functional or psychosocial, other social stuff, and they're all leading to a poorer quality of life and survival for people. So we're transforming these follow-up pathways, and it's a national directive now to address these for both patient needs and to also support ourselves with demand of these increased survival rates. So the number of people who are surviving and the quality of life that they're expecting. They should be personalised and stratified, so which we're going to talk about a little bit further on, against patient clinical needs. So a lot of factors will form whether or not people go down one way or the other way down the pathways. A lot of it will come from MDT discussions. Falling in with the NHS long-term plan, which by 2021, everybody who's diagnosed with cancer will have access to a personalised care plan, including an assessment or a holistic needs assessment or care plan, and health and wellbeing information and support services, whether this be a virtual method or a face-to-face method, depending on what is suitable at the time. After treatment, patients will move on to a follow-up pathway. So this will suit their individual needs. They'll have input into it, and it also ensures that no matter which pathway they fall into, they'll be able to get rapid re-access to clinical support where needed. And they won't have to worry about, obviously, unless if they've got issues and they think that cancer may have reoccurred, that they can get that rapid re-access back into the service. Interventions span both secondary and primary care. So again, it's that joined up approach, just looking at, obviously, cancer is moving towards more of a long-term condition. So we're looking at the interventions of both primary and secondary care and what we can do to support patients diagnosed with cancer. So personalised care and support plans, first part of the interventions, dealing with people's physical and practical, emotional, social needs, taking the holistic approach to patients and looking at the whole person, and targeting them with sort of these plans that can take this into account, and then provide them with the support services or signpost them to places that are going to help support these needs. End of treatment summaries, which have been around for a while but haven't always been used, are being implemented now into the pathways. So a copy of a treatment summary and a copy will be sent to the GP as well as the patient, which gives them specific details around things like potential side effects, signs and symptoms of reoccurrence, contact details of key workers who they may need to get into contact with. A lot of different things on that will drive other follow-up care plans and things with patients. Health and wellbeing information and support. So patients can sometimes access health and wellbeing events within the community, or it may be that they drop into a centre within the hospital, or they do turn up at GP's primary care for more support on issues. We'll have recognised health and wellbeing pathways to support patients and to help them with things about diet and lifestyle, exercise, financial support, all those kinds of things. And cancer care reviews, which will form a big part of the personalised care programme. With personalised care and cancer care reviews, the holistic needs assessments that we'll talk about, the end of treatment summaries, the health and wellbeing information and support sessions should all feed into driving that cancer care review and make it much more bespoke for the patients and personalised. A lot of information provided prior to that so that we have an update with where the patient's at with regards to treatments and things, and also what kind of concerns they might have prior to the review. So on the left is an example of a holistic needs assessment. So it takes into consideration a number of different factors beyond just physical concerns for patients. And the patient is given that, and they can either do it digitally or they can do it in person, on paper, tick the concerns and have that informed conversation with a health professional then who can help signpost them to the specialist services that they need. But again, the HNA should inform the cancer care review. So a copy of that should be with the patient. A copy of that should also go to the GP. The treatment summaries is a document produced by the treating team after a significant phase of an individual's treatment. This will again be detailed about what the treatment the patient has had, primary concerns that they might be involved with it, any follow-up treatments that the patient might have. It's designed to be shared with the patient as well, so they're informed about what's been going on. They can take that with them to any treating service and be able to present that so that people have an understanding of what they've been through, what kind of treatments they've had, and any concerns that they might have with that. And it helps them to manage their health and well-being through that. So the treatment summaries and the HNAs, again, mentioned, inform the cancer care reviews. A bit of a copy of the treatment summary here. You can see the top section of it gives you an idea. Looking at the summary of treatments and things that have been on there, possible treatment toxicities and late effects that may be on there. The second page shows you any ongoing management plans, any further tests that they might need or that are scheduled in, any alert symptoms where they need to refer back into specialist teams, key details of contacts, and any additional things around things like benefits and dietetic appointments and services depending on what the patient needs to support them. And a bit of an overview at the bottom, that kind of a bit of a summary to sum up where the patient is at the moment, concerns and what they might have and what additional support they might be looking for. You can see circled here, particularly things around the alert symptoms and the patient's current status of where they need to be, and what their understanding is of these alert symptoms when they know to go back to the specialist treating teams. So why are we looking to stratify? So many outpatient appointments at the moment may be to convey test results to a patient. It may be that they're making a specific journey back to hospital to have these test results, when it may be something that can be done in a digital way or over a phone call and free up the specialist time and also the patient travelling time and costs that might be associated. The demand on specialists as well is increasing. It says by 3% per year. This is to do with incidence rates and also improved survival rates. So freeing up the specialist time for treating other things, as mentioned further down, so metastatic diseases and complex diseases that might require more intervention from a specialist. It also creates more demand for personalised care. So people are more involved in their own care plans and their support. So this is, again, moving towards that personalised care support system. And also creates more fast-track clinic appointments for quick re-access. So we're stratifying people who can still get back into the system should they have any issues. And by freeing up these appointments, these routine appointments that may have been in place previously, we can create more of these fast-track clinic appointments. So looking at the pathway, so we've got end of treatment leading into a multidisciplinary team discussion. From that point, the patient's discussion turns towards an end of treatment review appointment with the patient, of which they will be given details, information and support depending on which pathway they're going to be on. So they can either move towards the supported self-management pathway, or they may have more of a professionally led follow-up pathway, a bit more of the traditional route. They'll be risk stratified at this point at the MDTs and then continue along the pathway depending on the outcome of that, but obviously with patient involvement as well. So an eligibility for professional-led follow-up, maybe patients who are unable to self-manage. It might be to do with physical impairments or cognitive function impairments, communication issues, emotional reasons, or they may be unengaged. So they may need that professional intervention to keep them engaged with the service and the follow-up. Patients may have other comorbidities that might require that they have more intervention, and any oncological concerns that they may have would lead them to be on the more professionally led follow-up. As you can see at the bottom, in general, everybody should still have access to the personalised care information, the information on signs and symptoms of reoccurrence, the health and wellbeing support, the self-management part of it. Patients will be looking to self-manage as much as possible alongside professionally led follow-up. End of treatment summaries will still be given to them, and they will still be having surveillance scans, rapid re-access and telephone support. And also, as mentioned in the bottom corner, cancer care reviews. So the principles for more of a self-management pathway. All clinical evidence-based surveillance investigations will continue. So those will still be in place as usual, and there will be somebody in place, which I'll show you in the next slides, who will deal with those investigations and arrangements. There's more robust systems in place to ensure that the monitoring and investigation of these surveillances are carried out and the requesting of results. And there's a fast track re-entry for clinical reviews, so patients aren't even on the self-management pathway and cast out into community without having rapid re-access if required. And they'll also further down the line have access to an online portal, which will be available at a future time, maybe looking at people reviewing results or managing their own follow-up schedules and tests at a later date. But again, as mentioned in the bottom corner, you can see that everybody should still have access to those key points. So why do all this? Why have all the self-management and things? And we're looking at this as an empowerment for patients now. So we're having a lot more patients representation on pathway boards, a lot more representation in treatments. So now we're looking at empowering patients with supporting themselves post going through the treatments, going through the procedures, and how they can improve their own knowledge and skills and confidence around their condition and managing it. So looking at the self-management circle, we're improving the self-management by looking at health coaching and health literacy for patients, understanding their conditions and understanding why it's important to have understanding of lifestyle changes and to reduce the risk and impact of any kind of reoccurrence. That self-management education, understanding why it's important that they change maybe their lifestyle or look at exercise and physical activity differently and being engaged in that kind of process. And peer support that's available, groups out in the community, other people who've been through it, who run groups, user support groups and things where they can get that self-management support, not just from a professional, but also people with lived experience. So currently at WWL, so BREST was the first human group to introduce the patient stratified follow-up pathway. They're currently still in the process of rolling it out fully, but we've had a Greater Manchester Cancer funded BREST Aftercare Coordinator currently, who started back in March, whose job it is to organise all the follow-ups for patients, and once they've been stratified, they will coordinate those calls to the patients who need those calls and kind of deal with that side of things. The colorectal team will be also on this pathway. The CNS is already having nurse-led cancer follow-ups, and they also will be GM funded for a colorectal aftercare coordinator for 1 year. Haematology is a pilot site for Wigan, so we've been an early adopter in the haematology route, and we're looking again at getting somebody specifically from GM Cancer Fundings to be an aftercare coordinator for haematology, so to look after all those follow-up appointments. And again, this is already has a CNS-led cancer follow-up clinic. So Greater Manchester Cancer has provided an IT system for us with the startup and 1 year costs, which will help remotely monitor patients for all the patient stratified follow-up. Using is Infoflex, which has been chosen as a preferred system because it's implemented across GM. So patients who are maybe diagnosed and treated at a secondary or tertiary centre may not be treated specifically in Wigan. They'll have their details passed through the one system, the Infoflex system, which will join up all those treatment summaries and needs assessments that we've talked about and ensure the patient pathway is much smoother. It'll be hosted on the Greater Manchester Cancer digital platform, which is interfacing across all the local trusts, again linking all those trusts up together with regards to the treatment centres. There's potential to link up in the future with current primary care systems, so depending on which system primary care practice already uses, we'll be able to link up again into the Infoflex system and a bit smoother in sharing those patient details across, sharing the HNAs, and also hopefully the cancer care reviews that are done will be able to be shared on the platform to inform the secondary care and join it all up together. Future developments include a patient portal, so there's potential there for patients to access their results directly, but that's much further down the line at the minute. So a third of primary care practices at the moment in Wigan have had some Macmillan recovery package training, which includes the holistic needs assessment, the treatment summaries and the cancer care review support. This provides personalised data for the patients as well to the trust. So for example, you can see below, we'll be able to give information around the number of referrals for patients, which tumour group they're coming from, and then also what we call a conversion rate, so looking at the number of diagnoses based on those referrals and where the largest numbers of these are coming from. And this will hopefully help to drive support services locally from the practice area and support those patients in those large groups. As mentioned previously, the cancer care review will be a large part of the personalised care programme. This is discussion between either your GP or your practice nurse within 6 months of a diagnosis. It helps to inform them with regards to the outcome of treatments, any ongoing treatments, their diagnosis, recurrence monitoring, and also an opportunity to signpost patients into community services or support services as needed. So looking at some tips for the cancer care reviews as well. At the moment, I don't believe that the cancer care reviews are standardised in any particular way, but some of the information on these 10 points has been raised from information provided by Macmillan around cancer care reviews. So looking at the most appropriate ways, particularly at the moment, with regards to things like face-to-face appointments or virtual appointments, depending on which is better for our patients. Cancer care reviews, again, dedicating a time slot to those. So ideally it would be a double appointment, but if not possible, at least a dedicated 10-minute appointment. Maybe patients are given information prior to this cancer care so that they have an idea of what the review is going to be about and the questions and concerns they might have. Inviting patients to involve other people, family members or carers or close friends, if they'd like to bring somebody along for support. Using a cancer care review template, if possible, it can just help drive the conversation and direct it and ensure that all the necessary questions are asked at that point. Again, I mentioned sending patients information in advance to explain the nature, just to give them an example of kind of what kind of topics will be covered in the conversation. And again, to keep that, if it is a 10-minute appointment, to keep it directed on the patient and checking patients' understanding of the treatments and late possible. So they may have been given this as a treatment summary. It is possible for patients to refuse that treatment summary if they would like, but if not, this isn't the time to check the understanding with regards to that treatment summary and that they understand exactly what's on there. So a recommended structure would be discussing the diagnosis, looking at the treatments and the potential consequences of that, a medication review, finding out about the support networks and agreeing any potential follow-up appointments. The concerns may not always be medical, so it may be that they have a link worker based in practice who can look after things like financial support or housing issues or other things that may be contributing to patient needs. So again, an opportunity then for a little bit of signposting into community services. Using the appointment as an opportunity for promotion as well. So personalised care is around improving people's health overall, and it may be an opportunity for them to signpost to other services that may be relevant to help with general health and well-being. And when complete, the CCR should be shared again with other professionals, oncologists, CNSs, support workers, etc. This is in there again to look at linking up holistic needs assessments, treatment summaries and cancer care reviews together to complete that whole pathway and package, so everybody who's involved in the patient care can have an access to that and understand where the patient sits currently. So recently at a virtual practice nurse forum discussed potential education topics, so future training events, anything that they felt that they needed further information and support on to facilitate the personalised care programme. The questionnaire had been sent out to practice nurses, and once the results from that come in, we can look at driving the treatments, information, the specific tumour group information and patient support services, for example, and can provide information on supporting those. Hoping to develop a training programme with them and to do regular updates. And there's a potential, after discussion, we're looking at explore how coding can be integrated more into some of these holistic needs assessments and treatment summaries to help improve those communication channels and obviously support our patients then. So in summary, so what does this mean for primary care? So systems and processes are still in place so patients do not get lost, and GPs won't have to do the requesting of any future scans, etc. Again, the aftercare coordinators sit in these roles to help deal with the requesting of scans, etc. So it doesn't mean an increased workload from that. Pathways will continue to operate as usual, with the biggest change being the use like of remote follow-ups. So patients being followed up remotely on the pathways, and GPs should be receiving HNAs and treatment summaries. Again, these are to inform those cancer care reviews and make them better. In that sense, you'll have more information provided beforehand to be able to drive those cancer care reviews. Thank you for listening, and if there's any questions, we can take those.
Thanks for that, Matt. A few people have joined us since you started your presentation, and so I'll leave a space for them to ask any questions. But I wrote a few things that I found helpful to summarise. You summarised them well at the end. But I think also as well that the cancer care review is really an opportunity for us to transition the patients out of the secondary care kind of immediate management, but also into that kind of disease model as well. So that's a useful way to kind of frame it as a GP there. One question that I personally had is if patients are using an online portal for getting their results and things, how do we know how the unfavourable results are going to be communicated in that way? If there is something on a follow-up scan or result, would patients then be invited in rather than using the online portal? How will that be managed?
Yeah, Rob, so patients will be invited straight back in to a clinic setting if there's any abnormal results.
Okay, thank you.
Yeah. It's that rapid access back in the system again.
And from those of us who've joined us, thankfully, is there any questions from you guys at all? Thank you for coming, as I say.
No, thanks. Everything was all right. Thank you.
Thank you, Dr. Van Speld. What we'll do is I'll put a link into the chat now for you. The whole presentation, if you missed the beginning of it, will be shared on the GM Training Hub. And I think Matt was going to share some links about the personalised care plans and and some of the Macmillan templates that we can be looking at to inform our cancer care reviews. So I'll put all them on there, and Alexia will be emailing out the link for that as well.
Absolutely.
Okay, thanks.
All right. If no further questions, I'll draw it to an end punctually on past. Thanks for joining us, and thanks to Matt and Catherine for doing that presentation as well. Thank you very much.
Thank you.
Thank you. Thanks.
Bye now.
Bye. Bye.